This is Lynn Fraser. I'm excited to be here today with Dr. Les Aria for the Radical Recovery Summit. And he is a pain management specialist, a non-opioid, mindfulness-based psychologist who has a lot of experience in this field. And as we get started, Les, if you could maybe just tell us a little bit about your journey. And I'm really interested in the process that you use with people. How do we get from being hardened and suffering with pain to being able to live more freely again?
Yeah, absolutely. It's great. And so I got into this field accidentally and partly in doctoral, when I was in my doctoral program, we had something called a clerkship, and we got exposed to different specialties. And one of my instructors, Dr. Richard Gevertz, very famous for biofeedback and heart rate variability, said, "Why don't you try pain?" And I thought, that's great. And there's lots of physiology and the mind involved in it. And so I did the rotation. So excited as I sat and shadowed this most senior person, clinician. In that first exposure, in that first visit, I found myself in a clinic, in a room with a patient with chronic pain, demanding for opioids and flinging the stool across the office. And at that moment, I said, I'm done with chronic pain. I don't want to. Well, 2 decades later, I'm in love with chronic pain. And the story goes that it's because I was fearful of not knowing how to help these individuals. And I stayed away. We often tend to, things that we fear, we stay away from. And so 2 decades later, I'm in love with chronic pain. I have a passion. If anyone has a year, I will bend your ear and speak to you 4 hours nonstop about that. And that's the passion I have. And the thing I discovered in this journey recently is that chronic pain actually found me. I didn't find chronic pain.
So, can you say a little bit more about that? So, you got
Yeah.
excited about the possibilities?
I got excited about the possibilities because I discovered that really, and this is the part where I really love the work. Part of my job is to really help people explain to them is why do they really hurt? And this is the part of modern pain neuroscience. And it's similar to, and I want to share this with you, it's similar to when clinicians used to believe, physicians specifically believe that the world was flat, for example, that mentality, and now the world is round. We're kind of stuck in this conundrum of is it flat or round, meaning that is this because of my body is damaged or is it because it's the nervous system or the brain? And so we have two separate groups of people who tend to still believe the old science. And the sad part about this is the medical system seems to unfortunately perpetuate this. And I don't believe they're being bad people. We know what we know to the best of our knowledge to know what we know. And so in medical school, they're taught dualism by some fellow named Descartes. Descartes was a philosopher, a French philosopher, Rene. He says, I think, therefore I am. So you exist because you can actually see yourself. And he goes on and writes about that. I was very big on philosophy in undergrad. And he talks about dualism. And by the way, just on a side note, Rene Descartes' father was really mad at him for not going to medical school. And Rene Descartes traveled the world, gallivanted around the world, and finally came back home and his father said, you got to do something with your life. And he says, oh, I'll go lecture at school, at medical schools. And this is the fellow that separated us. The dualism occurred from there. It's called the Cartesian Model. If
Right.
something is broken, the toe is broken, or you're feeling pain, let's fix it, and the bell up here will not ring. Well, that's old science. That's equivalent to the world is flat. Modern science says that is not so. This all comes from a reservoir, for example, of the brain. And the brain communicates with the body, and the body communicates with the brain. It is one system we call the nervous system.
That's a really persistent error in thinking. And it takes a while. Like when I was talking with Gabor Mate, he was talking about it takes at least a generation. And that there are a lot of people in medical school now who are really interested in trauma and the nervous system, but that medical doctors, it's starting to change now, but you get really literally nothing on trauma in their training.
Yeah.
So how could they possibly carry this kind of knowing into that? So like you had to kind of discover a lot of this and see for yourself through your clients and patients and what is true, what works, what doesn't work. So the whole mind-body connection, the nervous system. So we were talking before about Dr. Stephen Porges.
Yeah.
and the safe and sound protocol and how it works. Do you want to talk a little bit about how your work with that?
Yeah, absolutely. And it's part of my system of training, retrain the nervous system. And I'll just mention my model system. So, and this is the part where I get teased that maybe I'm my OCD because I like things in threes because it's simplicity to me. Actually,
Hmm.
that's the truth. Is that I call it the three R's. So the first R is basically to re-educate a patient on why do they really hurt, and that's basically saying is the world is not actually flat and the world is actually round. And so I go through some pain neuroscience, modern science, and we do different experiments in sessions and whether I'm doing groups or not. And it always starts with re education. That's the first R. The second R is basically the retraining, which I'll talk about the SSP, what it is, how I use it, and the benefits of it. So, re education is the first R. Second R is to retrain the nervous system. And then the third R is basically to re engage into activities that you once give up and get back into it. So that's the exciting part I really love doing. It's basically like exposure therapy and getting people the skills and all right, you're ready to jump out of the airplane now. And there's still this pushback of no, I can't do this. And then we remind them of the skills. So and remind them that they're safe. And it's not just a cognitive thing, it's about coming back home to the body. So at that point, we've got the re-educate, the retrain, and the re-engage. And it's not stoic, so it seems to move. So sometimes when you're trying to get back to the things that you love to do, but you're fearful of the pain, you'll pull upon the training and skills and then remind yourself. So it's not static. There's movement and there's always re-education in all three in that sense. And there's always skills applied. So at this point, let me just kind of share with the audience and you is this. The Safe and Sound Protocol, referred to as SSP, is basically filtered music that sends cues of safety to the nervous system, the brain, and the body. And I love the fact that I was kind of excited. I love the era of 60s, the 70s, and 80s. Great music, great movies, right? And so as you listen to the music from the 60s, 70s, and 80s, the frequency changes. And it changes through the vocals. So you'll hear cover band music and great music, and you'll hear sometimes the distance of the music, sort of an echoey. And that system helps send the messages of safety that I am safe. Now, I'm being reductionistic. It's of course very complex. It goes through the middle ear to the vagus nerve, and then the vagus nerve to the brain, and then the brain to the body in that sense. And so there's this bidirectional effect. And it is so powerful that it is one of the most important foundations of resetting the nervous system. Now, in my clinical work, I help people get off opioids with a team of physicians and pharmacists. And that is the foundation. And what's really cool is the addictionologist, the physicians who are trained in this, and also the therapist, have now come to realize that we do a lot of talk to try to convince someone that where they're going is not helpful. Now, they don't try to do this where you've got to get off the meds. They basically kind of do a lot of talk. And there's a lot of pushback like, yes, I want to, but I've been on this for 20 years. Yes, I
Mhm.
want to, but I can't. You don't understand. I have depression and trauma. I have pain. And so what happens is this is I've stepped in and said, let's stop the talk and let's start the nervous system training. And so using the SSP seems to reduce the not just the psychological defense, but changes the physiological states of the autonomic nervous system from sympathetic dorsal, which is what I call chronic pain that's stuck in sympathetic stress and wanting to freeze and shut down. And we're
Mhm.
stuck in it. When I cannot fight or flee from the pain, I tend to be in a flare up or want to hide and shut down. I feel depressed. And so we're caught in this oscillating movement in the autonomic nervous system between sympathetic and dorsal vagal, again, from stress to shut down. And when we get people with opioids, trauma, and or chronic pain, all call three combinations is we listen to the SSP. It shifts them from that state of defense to a state of safety, which then allows their what we would psychologists say mindset to be more accessible. But I want to send this message to everyone, and this is something I had to discover myself in conversations with Porges, is that your physiological states determines your psychological states. And therapists and addictionologists and addiction specialists often look at, we need to change your mindset. But if we change someone's breathing, you'll notice that they might be more accessible. So
Right.
that's something I learned, and it's bidirectional. If you get caught up and you don't realize you're getting drunk in your thoughts,
Hmm.
drunk in your resentment and victimhood, you seem to activate your physiology. So it's a bidirectional. But the message here with the Safe and Sound protocol is really to shift that state of defenses so you're more accessible towards healing. And we mentioned this offline is that I've truly come to believe that it's nearly impossible, not impossible, but nearly impossible for anyone to get into recovery, may that be addiction, trauma, and or chronic pain, until you feel safe enough.
Hmm. Yes, and like Dr. Porges says, safety is the treatment. So
Yeah,
then that gives us a lot of hope for people because it is possible to stabilize the nervous system and to get regulated. And it seems kind of weird that we could listen to that music, and I've done that protocol too, and the music's great. It's
yeah,
very enjoyable. And as far as the treatment, a lot of the treatments, especially that involve going into past traumas, are pretty difficult. But here you are just listening to this great music. So it's pretty amazing that the science behind it can actually shift us into a ventral vagal state where we feel safe enough to then engage with you or the
yeah,
practices.
yeah,
Mhm.
absolutely. If something comes to mind as you just spoke, and just triggered something in me here. I want the audience to know this is I found a pattern with, and I've shared this with Porges and the Unite team, the company that puts out the SSP. I've discovered so this is I've come close to almost 1,000 patients I've seen with SSP. So it's I tend to be yeah, someone had mentioned it to me. That's why. So I didn't realize. So in the past 2 years, I've been only using it for 2 years. So I don't want to say that I'm an expert in it. I have a decent amount of experience in it. I'll just leave it at that. I've discovered three main categories that when folks listen to the SSP, so three main categories. And again, whether it's addiction, whether it's trauma, whether it's chronic pain, to me, it's the same brain networks, different shelves of the pantry
Mhm.
of the brain. And so, with that said, with that foundation in mind, I've noticed three categories. I've noticed that when people get done with the SSP treatment, I find out that they tend to report, this is by accident, and then I start to track it.
Mhm.
They report at least, and again, I'm being arbitrary here, about a 50% reduction in anxiety. Now, anxiety, as Porges and I have talked about, and sort of my colleagues, is a psychological word that we made up to show that, this is what we're feeling.
Mhm.
But the proper word should be threat physiology, right? So, and that's the Porges language is what I call it. But I've noticed three categories. People report a reduction in anxiety. We're talking generalized anxiety, just intense anxiety, just worry, or rumination, and even obsession. I've noticed a reduction in anxiety. First category that I've noticed that what the effects are. The second category of benefits of the SSP I've noticed is a reduction in the pain intensity. Now, there are some exceptions where there's complete, and this is going to be very difficult for anyone to really appreciate or understand, complete resolution of the pain. We're talking,
No pain.
gosh, my migraine is gone. I'm no longer having daily headaches. That intense burning pain in my lower extremity, it's actually just a cramp right now. And so it kind of blew me away, and I thought, oh, maybe people are making this up. So I was skeptical, and I kept on asking that. So reduction in anxiety, reduction in pain intensity is what I call it.
Mhm.
And then the third category, which is by accident, what I do is I have patients when they get done with their each session, and so I do a 10-day protocol. And
Mhm.
this might be too much details for the audience, but ultimately is it's traditionally done twice a day for 5 days. AM and PM, for example. That's a 5-day protocol. So most of my patients with trauma could not tolerate 5 days. It was too much.
Mhm. Mhm.
So with Porges' blessing, I got 10 days and I got that done. And I noticed that the third category, besides anxiety reduction, pain intensity reduction, I got a report of clarity. And I didn't quite, I know what the word clarity means, but what does it mean? And I found out when people were making decisions, like I'll give you an example of someone that comes to mind right now. Someone with using, and the audience may know this, is the MMED, morphine milligram equivalent, was close to about 600 MMED. That's a very high for a long user, long-term opioids for low back pain and fibromyalgia.
Mm-hmm.
The person was given this over years, and this person was in a domestic violence relationship. And the audience probably knows this, and forgive me for repeating this, is psychological and emotional domestic violence is domestic violence. It's not just physical, right? So with that said, she was able to make a decision. She goes, this is not a healthy relationship.
Oh,
And so there was clarity, and so I thought, oh, it's just a fluke. But then I heard someone's like, this job is unhealthy. So I often forewarn patients as you will have clarity that may show up. Be wise and get counsel. Don't just be impulsive and make a decision. And
right.
so, and so the cool thing about that third category is, besides clarity, is I found another category of resiliency. Let me explain this. This happened to me, and maybe you can relate to this. One Friday, it's always Fridays. Clinicians will appreciate this. It's a Friday, it's 4 p.m., and I have 3 people who are suicidal. And I've got one on my phone, one of my nurses talking to one, and one's on hold, and I'm trying to get the other nurse to call for a welfare check. And the most intriguing thing is, it doesn't matter how many years you've been doing your practice. When someone is suicidal, really is activating, and I try to hold space, but it's still pretty intense because you don't want someone to harm themselves. And so with that said, after I did this, it was the most intriguing thing I've experienced about resiliency. I was able to feel the tornado pull, but not be pulled by the tornado. I was in the tornado of the emotions that I sensed, the difficult thoughts like, oh my gosh, what will happen? And the fear I felt in my body, and my back pain lit up as if it was yesterday for the injury. And so in this, I was able to hold space, is the best way to describe it. And when I got done, the after effects were not there. Usually you're fatigued, like, wow, what a long day. Try to get yourself distracted with, hours of Netflix, or, eating tons of ice cream or something like that, as a way to cope. But there was none of that. I was joyful. My body was light. And I thought, wow, this is pretty impressive. This is what my patients talk about as the third category: reduction in anxiety, reduction in pain intensity, and sometimes in some categories, complete resolution. And I've treated some really unique conditions that had complete resolution: reduction, pain intensity, clarity / resiliency. Amazing.
Wow. And that's just by listening to some cool music with all that technology in the background.
Yes, that's a great summary there. Yes.
So let's talk a little bit about the mind-body connection. So, Louise Hay came up with that in the 80s about, the liver means this. So can you talk a little bit about what you know about that? Because obviously there's a connection.
There is, and I love that question because it's something I love to practice and preach myself. And let me explain this to you in the audience here for the fun of it. Is my nurses know my shenanigans, and so if I'm in a meeting and I really want to bite my tongue, and if I stand up from the meeting and rub my knees, my nurses will ask me, so what are you angry about? And so I guess you didn't want to bow down. You're feeling controlled. So knees reflect sort of I have to bow down when I don't want to bow down. I'm being controlled. Now, I do want to let the audience know this is independent of the thinking of structure as the cause, nerve, or tissue damage. So suspend all of that and listen to the fact that the body is speaking because it listens to the mind. And my saying is, the body is the landscape of the mind. So there are beautiful flowers. Is it, desolate, rocky, pokey things around? And so the body is constantly listening to the whispers of the mind in that sense. Let me kind of walk the audience through a couple of my discoveries. Is sometimes, and this is Louise Hay's work, but and one that I discovered by accident. I'm like, oh, someone actually has been doing this for a long time.
Right.
When someone is someone has pain in their butt, who is the pain in your butt? When you have hip pain, mothers around the world specifically, put babies on their hips as they're doing their chores in general. So who is the person that you're carrying on your hip that you feel so responsible for? You have shoulder pain, you're carrying the weight of the world on your shoulder. What is it about? So sometimes your life shows up in your body and it confuses the doctor, especially when there's no injury to be found, or even when there's something found, medical treatment does not seem to resolve, nor opioids. And one last thing I wanted to mention, which comes to mind, a patient I recently saw who had wrist pain and carpal tunnel bilateral, and so both hands. And so went to my buddy who checked for nerve pain and said they put this long needle in, very painful assessment, and said there's no nerve damage, tried different medications and all of that, and still was not better. And I asked her one question. I said, besides your wrist hurting, what else in your life is hurting? Or what is it in your life that you have your hands tied to? And it was something in her life that she couldn't get out of. It was a relationship issue she felt obligated to be in. And her hands were tied because that person, her partner, helped her through a difficult time and she felt bounded by. Once we address that interpersonal and intra-psychic issues, the conflict, the pain resolved, which is really almost unnerving, pun not intended, that I myself, after 20 years of doing this, I'm still blown away. So I'm quite entertained by all of this, that the body does speak, or as Bessel van der Kolk would say, the body keeps score.
Right. So what's the difference if you have pain in your left side or your right side? Is it the same?
Yeah, great question. It's not quite the same. And in my 20 years of doing this work, by accident, I discovered this because I tend to be my best patient and subject. And so I noticed that when I speak, I'll give my mom an example. My mom's a wonderful lady, and thanks to her, I'm in this field. She says, "Please don't tell everyone that you're a psychologist because of me." So she says, "What did I do you wrong?" And so sometimes with my mom, and I'm speaking to my mom, and to be respectful, I might bite my tongue if she has a criticism. She's your mom, and so I'm like, let me just kind of keep some boundaries here. And so when I bite my tongue, when I don't speak the truth, my right side tightens up. Doesn't matter where in your body. So right side could be associated with suppression of anger, complaining. So the left side could be associated with whenever I talk to someone who is an authority, like a police pulls me over, or someone who has authority over me, or I am trying to control something I have no control over in my life, like trying something like COVID uncertainty. I noticed that when I went to the store for the first time, when COVID was all the toilet paper and water was being zapped, right? I noticed standing in there, my left side of my body started to hurt, and I noticed left chest pain. My left back started to hurt. So I would tell the audience members is pay attention, because the left side, left hemisphere of your body and the right hemisphere has emotions associated that I've discovered, and it's intriguing. And I use that as a body map to help my patients notice. And it's one of the most important mind-body practices I can teach. It's so practical. You don't have to believe it, but when you walk away from this video, when you are engaged with someone, check and notice which side of your body is more dominant with pain. And that will allude you to what the emotion is that you're actually experiencing. And you can work back with it by actually sitting with it with your breath and soothing it. And there's a way of doing that, mind-body practices. But the body speaks. Are we listening?
So as you're talking, I'm just thinking about, I've had some knee pain in the last several months. It's primarily in my left knee. And, if I'm thinking about what am I afraid of, that kind of, if I can't manage my body out here, I live in the middle of nowhere in an off-grid cabin. I need my body to be pretty healthy, or I'm not going to be able to live here, right? So I do have a physical injury from years ago in that knee.
Yeah.
But both knees, kind of carry my body around. Yeah. So why is it that the left knee more than the right knee? Right?
Great question. And this is not to minimize or dismiss any validation of structural issues. The response I have is it may not better account for the causality of the pain. It might account for maybe 10%, 20%, 50%. I don't know. But what I can say is there's another system that's playing a role, and that's the nervous system when it senses. So let's put two and two together. So let's just say there is an injury. And by the way, I do have a very severe lower extremity injury that resulted. And in that sense, when I'm on my run or I'm doing my CrossFit, lifting weights, doing squats, and it fires up. And so because there was some structural stuff, but my mind sets in and does not set in and say, "Oh my gosh, this is going to hurt." I basically thank my pain system for coming alive. I'm like, "Honey, thanks for." It's kind of like a kid saying, "Hey, mom, hey, dad, do you need this piece of information?" "Oh, honey, right now it's not helpful, but thank you though." And so
Okay.
I'm very kind to my mind and body in that sense. It's kind of almost sickening. As one of my patients said, "Do you really talk to yourself that way?" I do. And so when it comes to needs, so we want to be very, very compassionate to the sense that there might be some portion, but based on modern science, we can say this is that is the nerves and muscles around the knee, the structural issues, have been sensitized, and the brain has created a habit in service of protecting you. Now, you add anything else in your life that may be of uncertainty, it will light up that system. And so to take a step back here is well, not the left or the right. I simply ask for people to look into their lives and then ask which better accounts and what can you do. And here's the cool thing. If you actually create a new relationship on how you show up to the pain and dial that down with a sense of safety, and there are different mind body practices.
Mhm.
And one of it is pendulation that I've stolen from Peter Levine. And it's basically from something pleasant to unpleasant. And what I do is most of the time when we feel pain, we want to do how do we get rid of it and push it back or ignore it. That's like ignoring a 5-year-old who's saying is, "Will you play with me?"
Right.
So will we push that child away? No. So you show up. So learning to relate differently to what showed up is the key to transforming the nervous system in the pain system.
Well, we know that fear and anger and all kinds of emotions lead to more inflammation in the body
Yeah.
and lead to kind of an inflamed nervous system as well. So it really makes sense that if we can calm our system
Yep.
and just have more regulation, that our mind is better. I used to be really compulsive in my mind. I was always, well, what if this happens? What if that happens? And through many years ago with meditation, that doesn't happen to me anymore.
Yeah.
If it does, I notice it. I'm like, yeah, I don't need
Yeah.
to go there. So I've really retrained that pattern. And so, like you're using yourself as your own best patient because we can really be aware of what it is that's going on inside
Yeah.
and be very kind with ourselves. So, if you look at this kind of as a long term, how are we as a society managing pain? So
Mm.
we got into a lot of trouble with that mind body split.
Yeah.
And you've got a pain, I'll just give you these opioids. And then we got into this huge opioid crisis.
Yeah.
So many millions of people have died and been really affected by that. So, how do you work with someone then who's been on opioids for a long time and says, I don't believe that I can make it without this?
Yeah, it's true. And very often beliefs or habits, and those habits serve a purpose, conscious or unconscious. And so it's kind of like when someone likes chocolate ice cream over vanilla, and it's just palate they've developed. In the same sense, I don't really see patients as the bad people, and then I don't blame the doctors. We always do the best we can with what we have in that moment,
Hmm.
right? And so I start from that framework. Now, how do we work with that? Probably the best thing that I've discovered with my work is this is if I can actually get the nervous system to be less defensive. This is unique and a different approach. And so I work with a lot of people who have high MMEDs, that's morphine milligram equivalent uh,
Hmm.
dosing. And one of the most difficult things is to give up something, just like any dependency or codependency or addiction. It's hard to give up something because it serves a purpose. And even though it may not be giving us a full life, it's a form of protection, much like alcohol, for example, and some of the
Hmm.
clients I work with pain. Calm the nervous system down, reset the nervous system, and there'll be greater accessibility to change and amendable to rehabilitation. We have, to some degree, got this wrong. And what I mean by that is that we try to convince people to some degree bad, 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 no, no, no. And I know no one out there is really, really doing that, clinicians and trained people. However, a lot of my patients come back and tell me is a lot of that talk stuff doesn't really work. I want to change, but my body's not letting me.
Right.
That's a wake up call for us to go is let's kind of look at this differently. And so what I do is this, and again, it's not that the right way and the only way, but a way in I found out to help people shift into rehabilitation of their recovery of addiction, trauma, and or chronic pain is to actually calm the nervous system down. How do I do that? Always start with, I don't do the talk therapy. I don't do a whole lot of education. I'll do a little bit of modern pain science education if they buy into it a little bit. It is when I actually apply the safe and sound protocol, the filtered music, that
Hmm.
shifts them out of the physiological states of defenses. And chronic pain, the way I define chronic pain is basically it's the nervous system is stuck in a state of sympathetic and dorsal vagal. In English, stuck between stress and freeze or shutdown. And we seem to oscillate that. And if we can change that circuitry into a state of ventral vagal, which is safety, it actually makes people more amendable. Let me just summarize this. When you are having a good day, you have head space, you tend to have greater heart space. So in
Right.
clinical work with addiction, trauma, and or chronic pain is when someone is not so defensive and resistive or rigid in how they kind of deal with the problem, we tend to be amendable to the rehabilitation. So the SSP is the prehab before the rehab.
Hmm. Hmm. Well, that makes so much sense. So we have all of these habits. A lot of them aren't working very well for us. We might feel a lot of shame
Yeah.
around them, especially if there's opioid addiction or any kind of addiction, really. Sometimes people really have a lot of beliefs that they're a loser. If they were better somehow, they wouldn't be in pain or they wouldn't be addicted. So, how do you work with that sense of shame?
Wow, those are great comments and question here is that I use the polyvagal theory. It's
Hmm.
been my saving grace. And for those who might be familiar with it, I used to be familiar with it several decades ago. In 1994, 1995, the first time I heard about it, I was sitting in grad school. Dr. Goodverts talks about it. I'm like, yeah, sounds like nothing special about it. Taught grad school, taught the polyvagal theory, just regurgitated it, didn't know what I was really doing, just did it.
Right.
And then I got into the fact that my patients with trauma and addiction was so shameful. This is after maybe about a good 5 years or 10 years of experience. I'm like, wow, my interventions are really not working and they feel so ashamed. They feel shameful.
Hmm.
And when I started introducing the polyvagal theory to explain why we think, why we feel, and why we do what we do from a neurocircuitry perspective, the autonomic nervous system, it was instantaneously de-shaming intervention there. I'll give you an example. I was referred a patient who the neurologist said and the psychiatrist said, we really don't know why she's doing this. It's kind of an unusual diagnosis. She had a history of binge drinking and severe childhood developmental trauma and adulthood, and also in a domestic violence, psychologically controlling spouse. The diagnosis is dissociative disorder, and they threw that diagnosis. And when I assessed her, she was basically having a trauma experience at that point and trying to leave a body because it was so overwhelming. What was interesting is she goes, I drink to actually numb myself out. And when I asked her, what's the explanation that was given to her by her providers, and they said, it's because of the trauma, and they're trying convincing me that wasn't my fault. And so in that moment, as she was talking, she was triggered. And she started to get triggered and she says, I feel like I'm leaving my body. And I said, listen to my voice. And so I had her look at me. I smiled at her. I said, I'm holding space for you. I said, I want you to do this with me. So I stood up with her. I said, stand up and take a breath and gently sit down and now open up your arms. So this is using the combination of Peter Levine, Bessel van der Kolk, and Porges' work. And in
Hmm.
that moment, I said, go ahead and settle down. And I worked with her right there and I stopped talking. And I did more movement. because more
Mhm.
talk seems to activate. And so I knew she was stuck in a sympathetic and she was going to shut down. And
Right.
so I started to play with it to get her to move, to get her up in the sympathetic. And I said, now I want you to hum a tune. And as the moment she started to hum, we finally sat down and she hummed Amazing Grace.
Mm.
And so as she hummed Amazing Grace, we stopped. And this took nothing more than about 3 minutes.
Mhm.
And she says, hey, I'm back. And that
Wow.
was a display of, and she said, what did you do? And she was kind of freaked out by it. She goes, you didn't tell me to calm down. You didn't tell me it's okay. And
Right.
I said, well, more talk sometimes gets us in trouble. And so I
Mhm.
said, this is the nervous system, and this is all coming. I said, you are not responsible for what shows up, but you are responsible to how you show up to what showed up.
Mm.
That is the polyvagal theory, teaching you that we're not responsible for what shows up. It's the autonomic nervous system in service of our survival. It's
Right.
there. Pain is a protector. Trauma is a protector. The addiction is a protector. And we do what we do because we're trying to figure out, how do I live in this state, in this body? The polyvagal theory basically helps us understand, the framework helps us understand that we're not bad people, that everything that we experience inside of us is in service of survival. And sometimes we have dogs and kids that do things that are not helpful. And it is our job as the healthy or parent to be able to retrain them with compassion and guidance and persistency with love.
And that can really only happen in an environment of safety,
Yep.
or it happens best in that environment anyway. Yeah.
Yeah, absolutely. And that's why sometimes, and I got this from Deb, and Deb Dana, I love what Deb Dana says. She goes, I've got some ventral vagal for you. And that basically means that I'm holding space with you. And sometimes I'll do this literally. And a lot of my consults, by the way, is on Zoom.
Right.
And
Mhm.
so, how do we do this? And so this is why I get individuals to breathe with me, to hold space. But ultimately, the shame really has helped. Many of my patients feel that this is not them, it's the nervous system, and they are separate from their thoughts, emotions, and physical sensations. They are not them.
Right. Right. So separate from that also would mean that they're not their pain, they're not their nerve pain.
Yep.
Right. So do you do kind of emotional work and therapeutic work in terms of, going back through trauma and that kind of thing as well? Or is
Yeah.
that what do you do with that?
Yeah, great. It depends, and everything is tailored. If I'm doing a group, it's a little bit more structured, and the intervention's a little bit differently. If
Mhm.
it's so, there are some, and I use a style of treatment that's not many have heard of, but it's very, very effective. Is accelerated resolution therapy,
Mhm.
ART, and it's
Mhm.
becoming more and more popular. It's more popular in the East Coast, Northeast,
Mhm.
and I use that. And it's really amazing that I'll give you an example. If someone comes to mind, a phantom limb patient, wonderful. He's wonderful now. When I first saw him, this is pre-COVID, came in with his long dickies. He had a strut down the hallway. He had tattoos all the way up to his face. He had a swastika, and he had a swastika here. He had 666 here. Let me just tell you this: moving forward, is he is a drug counselor now. His life is clean and sober. He is the most loving individual I've come across. Talk about transformation.
Yeah.
About a year for him to transform his pain. He had phantom limb pain, and he was trying to keep a job. He was doing drugs on the side on top of opioids, very high use of opioids and fentanyl abuse. And so got a team together to help sort of get him off the medications. But before we did that, we reset him. And here's what happens to bridge the trauma is that I worked with him, and his pain started to decrease, his phantom limb. So he was in a car accident. He was selling drugs, went down a highway, lost control, flipped it, and he lost his leg in that accident. So then
Oh.
he said, now I have real reason to use drugs, is what he told me when he started this.
Right, right.
Yeah. And
Like
so,
all the trauma isn't reason enough.
yes, exactly. That was interesting. Yes. And so as we worked with him, so he was very scary. And he says, are you the only one that can help me? He didn't like that I was a man of color. And what was intriguing about him as we grew to know, he would explode in session and I would just hold space for him.
Mhm.
And then he would tear up and weep. And he goes, you didn't cut me off. You didn't kick me out of my office. I said, should I?
Right.
And as we worked together, he realized that he could trust me and he could explode. I was able to hold space. And then I taught him how to calm and system down. I taught him how to actually notice, experience anger and where this anger was coming from. So, long story short, we worked through the using pain psychology program, the 3 R's: re-educate, retrain, and re-engage. He was doing great. He could put on the prostheses without much pain. He was off his meds. He was doing great. This is now 2 years, a year of that work, and then he went away and continued to work with an outside therapist for emotional regulation. And ultimately, I got into a class, and he says, "I want to be." He was now clean and sober for a year, and wanted to kind of, how can I give back? Got
Hmm.
into class, taking classes, got triggered in class, and it activated his pain again because the teacher called on him, and someone chuckled and laughed. He felt
Uh,
shamed, and he
yeah.
went back to wanting to use meds. But he came to me, and we did a little bit of the basic pain psychology work, pain recovery work I do, but it wasn't cutting it. There was a barrier. I'd asked him about trauma, but he minimized it. And
Hmm.
I know, and we know in our work that when someone gets an addiction, there's something there, there's trauma there
Yeah.
that may
There's a
not be
reason.
past or
Yeah.
not. He admitted for the first time in his life that he was molested by his uncle, and we did the trauma therapy. And when we did that in one session, which was intriguing, he was so willing to trust me, and we did this. In about 24 hours, the pain remitted, and he was back. Just to let you know, moving forward now, about 5 years later, beautiful family, two beautiful kids, steady job. And I said, "Hey," he says, "How do you like me? I'm in an Oxford collar shirt." His tattoos were removed,
Oh,
and
right.
he has a fulfilled life. So sometimes when traditional addiction recovery or pain recovery does not work, I go after the trauma issue and dismantle it. I remove the emotional charge, which seems to help the nervous system reset itself into safety.
Right. And you already had a really trusting relationship with him. So he
Yes.
was able to do that so quickly.
Hmm.
Wow. What an inspiring story.
Yeah.
Yeah. Wow. So, I think one of the reasons I like to do these interviews and to talk about this is because so often people don't have a lot of hope that they can actually change. And so these other regular people just like us
Hmm.
have healed, and that's so important for us to know.
Yeah.
Mhm. So will you talk a little bit about Menda? And that's such a fascinating process that it doesn't it seems a lot more accessible, the kind of work that you're doing there. Can you kind of
Yeah.
tell people a little bit about that?
Sure. Absolutely. Minda, out of frustration, whenever I get frustrated, step back. I tend to use it in a direction. At least my mom has told me that. So I was frustrated with the medical system and in a large organization I work for, and so out of frustration. So this was COVID, by the way. Who does this, right? So this is about 2.5 years almost now. At the peak of COVID, I said when I come out of COVID, and did this with two other colleagues, the co-founders of Menda, and I basically said we had an agreement: is we don't know how long this could be, 2 years, 3 years. We had a pact that when we come out of this, how can we actually improve ourselves in the world?
Mhm,
So 2 years later, we have a company called Menda, and Menda means to reverse pain,
mhm,
and Menda Health, that is. And so now what we do is we use modern pain science with evidence-based psychotherapy, such as, IFS, mindfulness, self-compassion, and ACT, acceptance commitment therapy. So we use a different way of helping people get into pain recovery. And this is the part. And we run data and we look at outcome data, and we have some wonderful changes, and which matches the latest evidence, pain reprocessing therapy, PRT, which basically says that you can help someone get into pain recovery, much like addiction. And
mhm.
so Menda basically uses a mind body approach. It's non opioids. And we basically get people into recovery. And it's an online program. We have an app. People can take a look at the modern pain science, because it was important for me to get the message out. Like, how do I get the message out that the world is round? That if you can
Mm,
understand why you hurt, you will start to move towards a better life. And so we developed an app with my two co-founders who are Silicon Valley gurus and amazing. So basically, some minds got together, developed it. And our heart's mission or our company's mission is to help reduce suffering when it comes to pain in this world.
Hmm. Oh, that's beautiful. So I'll put the links to that, but they would just go to the website and explore and see what kind of how they can get involved with that.
Yeah, absolutely.
Right.
We'll go to the Apple Store or the Google Play, whatever phone
Um,
device you have, and just type in Menda, M-E-N-D-A, Menda Virtual Pain Care, and it'll pops up. And you'll see my mug. So
right.
talking about modern science. So
Right. Oh, that's really cool. And so when people are listening to this, I'm hoping that they're getting a much greater sense that there's modern science now, that
yeah,
there's mind body techniques, there's the safe and sound protocol. There's a lot of ways to reset the nervous system. And I noticed you were doing a 478 breathing on one of your videos. So the message really is that there's something we can always do. We can always do something about pain. So if someone is still kind of in the, well, you know what? I have a bulging disc or I have something physically wrong. I'm still not quite convinced. What's
mhm.
kind of how do you work with that?
Yeah, great question, really. Is I don't try to convince. And again, I take the mentality of if you like chocolate ice cream, I'm not going to convince you that the vanilla is super superior. I'm going to
Right.
take you to just experience it. You will make that decision. And I call it the Sherlock Holmes method. That
Okay. Right.
so basically, you want to experience and collect the data yourself. And
Hmm.
so I do what I do in simplicity, perhaps the first visit or second visit, whether in group or in person. What we do is basically is like right now, let's have you kind of lean into the pain. And they often ask, what do you mean lean into the pain? I'm like, let's dip our toes into the water of what you're feeling.
Hmm.
And in a safe manner, and I walk them through it, and I use the 478 technique. And for those who are not familiar with it, I do it a little bit different than Andrew Weil does it. So it's laced with a little bit of mindfulness and a light sense of hypnosis. Let me explain. You breathe in for a count of 4, hold for a count of 7, and out for a count of 8 out. And so, but I have a countdown. The brain likes things that are rhythmical, and the brain likes to know when things are ending and starting. So
Right.
2, 3, 4, hold, and then when you hear the word hold, I'm counting down from 7 to 1. Wherever
Yeah.
you are, just whenever you're ready, take a nice gentle breath. In, 2, 3, 4, hold, 6, 5, 4, 3, 2, 1. Out, 7, 6, 5, 4, 3, 2, 1. And we do 3 to 5 of those breaths while you focus on that
While
discomfort
you
in your
focus.
body
Hmm.
and would come out of it. What was it? I didn't feel anything. Let's go back in there one more time, just try it again. Because sometimes this 478 seems to activate people because they're holding their breath. They're not used to it. And I often tell people, go to the grocery store, smell the rose, and savor the scent for 7 seconds.
Mm-hmm.
And when you can savor the scent, I'm not sure if you smell pumpkin pie or rose or anything like that. It's so good. I just don't want to let that cookies and cream, right? That scent of vanilla. And so I savor the moment. And when you can shift your mindset on, I'm holding my breath, oh my God, something bad is happening, to this is a beautiful
Hmm.
savoring of the scent. So, in that sense, the 478 is a great way to reset the nervous system. And that's what I use it for. And I can have someone feel the sensation in their low back. And often they come out of it, yeah, it worked kind of, but it's back. And that's the point, is this is where we begin. It's not about getting rid of the pain. And my message to everyone, and this is a difficult thing to say because not everyone's going to be happy with this, divorce the outcome and marry the process. Divorce the outcome of getting rid of the pain and integrate and show up for yourself. And when you keep showing up for yourself and providing that sense of comfort and shifting your nervous system, even at the worst moment with a difficult thought, difficult emotion, a difficult sensation in your body, with the 478, that's not the cure. It's a step towards down regulating your nervous system from a state of defense to a state of safety in the present moment. And that starts to shift into healing.
Well, that's beautiful. Yeah. So is there anything that you'd like to kind of finish with other than that? I mean, that's such a powerful example. Is there anything else that you'd like people to
I
know?
do. One last thing is when you get a chance, if it's very difficult to be in your body, I do know a little bit about that.
Mm-hmm.
And so when you find it very difficult to engage in leaning into your pain and doing trauma work or the addiction and recovery stuff that you're doing, and it's really tumultuous, let me just guide you on something simple that works really well. Instead of focusing on always what is bad showing up in your body, find moments, I call it savoring moments. Find moments throughout your day, frequently throughout your day, and consistently throughout the week is moments of when you actually have a sense of peace and joy. Let me explain. If you're sipping a cup of coffee and you notice that, wow, that was delicious and warm, in that moment, find that feeling or that thought in your body
Mm-hmm.
and seal it with your breath. 10 seconds. And when you start to invest in safety physiology, you can withdraw more often. So practice moving your nervous system towards safety and investing in it. So when the time comes when you have a flare up or an emotional flare up, you can withdraw from the bank that you've deposited in. So it's important to have a daily practice of calming the nervous system down.
Right, right. And you had talked about threat physiology and now coming to safety physiology, same science,
Yep.
the other side of the coin. Yeah. Hmm. I know I have a practice. I live near the ocean and in the forest, and the air here smells fabulous. And every single time I walk outside, I take a deep breath and just enjoy the smell. And I'm sure that's part of the reason I love living out here. Is
Yeah.
because it's amazing to be able to just tune into that several times a day. Yeah, yeah. Well, thank you so much, Dr. Les Aria. And we'll have all of the links to get in touch with you and to learn more about your program. And I love the approach that you have and the science. The world is round. And there are ways that we can really integrate and come back into connection with the body and heal the pain.
Yeah.
Thank you very much.
Yeah. Thank you.
Thank you for watching the Radical Recovery Summit 2023. To watch more of the interviews and the clips and to share with your friends, please go to radicalrecoverysummit.com.